Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and increasingly all sorts of other infectious diseases as well. This is the week of July 18th, 2022. We are looking at the start of school coming up in the not too distant future. Of course, therefore, there are increasing concerns and questions about vaccine schedules, both COVID vaccine as well as routine vaccines. And as I think we all know, unfortunately, Arizona is not doing so well in terms of a number of our children coming to the primary care provider's office for primary care visits. Therefore, our ability to provide routine vaccines is not 100%, and certainly it's nowhere near as good as we would like it to be. However, before we talk about that, we do have several questions related to the COVID pandemic. The first one references the last ACIP discussion in February, where the possibility of a longer dosing schedule or more time between primary doses could be both effective but also a way to reduce or mitigate somewhat the risk of post-vaccine myocarditis. And certainly as we look at now our younger children, ages 6 months up to 5 years, questions about trying to avoid post-vaccine myocarditis for that very young population are I think, quite important. So the questioner is asking, is there, as we talk to parents, is there a best interval to recommend based on available data to try and, both provide protection against SARS-CoV-2, but also reduce the risk of myocarditis? So to that end, the studies or the evidence supporting that have come to us both in terms of planned comparative trials, those are very small, but also from observational studies, especially coming to us from Israel and other parts outside this country, where patients, for whatever reason, presented somewhat later, and they were able to retrospectively look at a reduced incidence of myocarditis. So based on that data and also based on immunologic modeling, the CDC now posts, and you can find this on their website, now posts a recommended interval between the first doses of the Pfizer vaccine from 3 to 8 weeks. So keep in mind, Pfizer mRNA vaccine, which again is approved now for ages 6 months and up, between doses number 1 and 2, an interval of 3 up to 8 weeks. So one could postpone that second dose by 2 months after the first, still accomplish the immunologic protection that we're looking for, and certainly, realistically, decrease the risk of the myocarditis. So for the children from ages 6 months up through 4 years, so through the end of 4 years, they are on a 3-dose schedule. 3 doses, meaning we're not calling that third dose a booster. It is an important part of the primary series. So for those infants, 6 months through 4 years, interval between the first and second dose is up to 8 weeks, from 3 to 8 weeks. Interval between dose number 2 and dose number 3 is at least 8 weeks. So again, we're giving a full 2 months before or between the second and the third doses for the infants up to 4 years. For all the other ages, so ages 5 and up, the dose interval between doses 1 and 2 is that 3 to 8 weeks, so you could push it back to 2 months. And then the first booster, or dose number 3 booster, is at least 5 months after that second primary dose. And then for those who are currently available to get this, ages 50 and up and or severely immunocompromised, a fourth dose, second booster, can be given at least 4 months after the first booster. So that's for Pfizer. For Moderna, also approved for ages 6 months and up, for the youngers, so the ages 6 months, actually there's not a third dose per se, it's just the routine schedule. So all pediatric patients ages 6 months and up through 17 years of life getting the Moderna mRNA vaccine, doses 1 and 2 should have an interval of 4 to 8 weeks. So keep in mind, Moderna already was going to be at the minimum of a 4-week interval between the two. Now, per CDC's guidance, it can go up to 8 weeks as well. So I think realistically, as we encounter, I think appropriate parental questions about the safety of vaccination, especially for the younger kids, but still yet for the older ones, it is reasonable to offer the ability to extend that dosing interval out to 8 weeks. And it'll still provide good efficacy, good protection, lasting protection, as much as is possible against the current BA.5 and BA.4 strains of Omicron. But it will also apparently reduce somewhat the risk of post-vaccine myocarditis. For the Moderna boosters, so doses 1 and 2 split by 4 to 8 weeks. The third dose, which is the first booster dose, at least 5 months after the second, and then the fourth dose or second booster is 4 months after the first booster. So not a lot has changed other than the intervals between the primary doses, which now is pushed back up to 8 weeks. You know, the data which supports that is, again, it's going to be susceptible to all sorts of biases. But the key thing here is that the efficacy of the vaccines are still protected even with the extended dosing interval. And to that regard, I think it's reasonable to accommodate our parents' questions and concerns about vaccine safety and say, hey, yep, you're okay. It's all right. We can push this back just to make sure everything is A-okay. A brief word, I think, about vaccine uptake for the younger populations. Again, the most recently approved by emergency use authorization is the vaccine indication for 6 months through 4 years or longer for Moderna. You know, you would think, boy, this would be a wonderful uptake, because certainly we all encountered multiple questions earlier in the pandemic. However, the national uptake of this vaccine in that young age group has been, I'll use the words, abysmal. 1.3% of available vaccine recipients have actually received a single dose of the vaccine to date. That's it. 1.3%. So I imagine all of you boots on ground know far even better than I, like, what are the sources of pushback? What are the sources of questions? Very likely you may be asking those questions yourselves, and I fully understand that. Do we honestly have to vaccinate these kids? The risk for young children with COVID-19 is not high. Although I must say I have several patients in hospital right now with lower respiratory tract disease, again from SARS-CoV-2, likely to be BA.5, which is a return to some deeper invasive isolates, unfortunately. We still are seeing a significant number of COVID croup patients as well. So it's not a zero risk to the young children. Certainly if it's bringing them into hospital, putting them on steroids, oxygen, hospital-acquired infections, etc. And as a brief note about that, by the way, hospital-acquired infections have become significantly more drug-resistant during the pandemic, which is an unfortunate side effect and lots of effects causing that. But you do not want to get a hospital-acquired infection at this point, because chances are it's going to be highly drug-resistant. Back to the sources of, I think, decreased vaccine uptake. So parents are certainly asking, and I know colleagues have been asking me as well, why do I get the vaccine for the young kids if they just don't get that sick? And it's the same as before. Well, it's the never event that they do get that sick, or potentially now have an increasing risk of post-COVID MISC, MISC, as BA.5 may be a return to the bad old days of triggering post-infectious MISC. But also, these are the young kids who remain the plague vectors, to coin a term, and are likely to be highly contagious, highly infectious with SARS-CoV-2, even in the absence of overt symptoms. So certainly, I think we all have anecdotes of infants causing a mini or a super spreader event, and they were not vaccinated. So there is that as well, as an attempt to once again get this darn pandemic somewhat under control. It really takes a aggressive, extensive vaccine outreach to try and make that happen. That ship may already have sailed, quite honestly, as we have, I think, fixed a population in this country of non-vaccine uptake individuals. And to get after them is going to be a battlefield one by one trying to change their minds. That is not in any way a sense of hopelessness or futility, but simply a sense of the challenge facing us. So if we can capture a very susceptible patient population in this country, vaccinate the heck out of them, maybe that's going to help as we go into the anticipated winter surge, although we're currently in a mini surge from the BA.5 Omicron as we speak. Maybe that can do some good to try and further turn this pandemic at least into an endemic situation and reduce the risk to older and susceptible patient population. All right, enough of that soapbox. Question number 2 is also related to our COVID-19 vaccine, but more so to, I think, the isolation that individuals have been having. So the questioner asks, many of our 2 to 3-year-old patients, especially those in childcare, have been infected by, exposed to, and developing disease from other respiratory viruses, other viruses for that matter, common to childhood, and that's potentially, after a period of sort of self-isolation, the social distancing that we did experience before, we've all experienced this explosion in cases of norovirus and rotavirus and RSV and rhinovirus entero and even adenovirus. So yes, this is very true. However, there are still some kids who luckily have avoided that because their parents have followed a rigorous quarantine practice. And so those kids have not been in daycare, have not been exposed, have not gone to playgroup, and so far have avoided the multiple viruses out there affecting all the other kiddos. The question is for those kids who have not yet been exposed, is their immune system less strong or less able to respond to a virus once they are exposed? And immunologically, the short answer is probably not. Yes, I think we all have our own stories, especially as pediatric healthcare providers and teachers would say the same thing, that constantly being exposed to the viral plagues out there does create a strong immune system. It's not so much a strong immune system as an educated immune system, which has already been exposed to viral antigens and developed low-level protection, which starts to immortalize a cell line of lymphocytes, which then can react when challenged yet again. So antigen-naive patients, such as those few children who have not been sent back to daycare or playgroups or whatever, their immune system is no less strong, it's less experienced. So when they are exposed to viruses, they will have a full-fledged viral infection, just like all the other kiddos out there, and then will mount what should be a protective antibody response. So the concern about their immune system not working as well as I think, thankfully, not supported by immunologic science, but we're about to see like another whole host of kids that are exposed to viruses, virus X for the first time. They're going to get sick and come to the office and want to be cared for. So there you go. Those are the questions we have for this week. I think, as mentioned before, our challenges currently are what to do about boosting immunization uptake for the young children and also for those somewhat older kids and even adolescents that have not yet started or completed their vaccine series. Yes, it is true that we are facing a situation where SARS-CoV-2 is behaving now just like influenza A, especially even influenza B, in ongoing mutations, which are going to drive different vaccine discovery going forward, I think, for the foreseeable future, and also where kids are becoming the more likely to be the spreaders of disease, to be the plague vectors. And only by immunizing those kids, by boosting their immune systems to try and prevent direct infection, but also reduce their chances of being contagious. Only by doing those things can we still have a hope of going through this pandemic and perhaps shortening its course. So that is, I think, that the talking point that I would offer to you when our own personal questions and those of our parents come up. It's like, well, if not thinking of the safety of our child or our patients, perhaps think societally of how best to get through the pandemic. The other then is what's happening with the variants, and as mentioned, the BA.5 Omicron subvariant now accounts for well over 65% of new isolates identified in the United States. The BA.4 variant is another 16 to 20%. So together, those two are well over 80% of our new isolates being identified here in the States. It's unfortunate because both are at least threefold more contagious than the BA.1 and the BA.2 were or are. And it seems that at least in some early reports, the BA5 and BA4 subvariants are again targeting lower respiratory tract tissues, unlike the BAs 1 and 2 that we've come to expect causing upper respiratory tract disease, i.e. the sort of classic URTI with rhino, like a rhinovirus-like illness. So congestion, nasal discharge, slight cough, not too awfully sick, may be triggered into a reactive airway disease exacerbation, perhaps. And then, of course, the COVID croup illness, which is still strongly associated with the BAs 1 and 2. We're still seeing, COVID croup, if you will, but the patients in the adult population and those kids who are coming in with more recent disease are suffering again from lower respiratory disease, triggering asthma, triggering fevers, some GI component, etc. So the pendulum swings once again, and we're back into facing, as we do with the flu, a changing pattern of clinical illness and, of course, of risk to those of our patients with underlying comorbidities. All right, what else is out there? A brief update on monkeypox, which the CDC and the World Health Organization are going back and forth on calling an outbreak or a disease of concern or yet the next pandemic. Certainly in this country, and I think worldwide, the areas of the world that are non-endemic for monkeypox, so meaning everywhere outside of Africa, have seen a continued explosion of cases. The vast majority of these cases, 99+%, are occurring in typically middle-aged to younger-aged men having sex with men. So not a pediatric patient population, although kids are potentially at risk. It is the MSM population, unfortunately, that are encountering viral spread at super spreader events. Here in Arizona, there have been several occurring up in the Phoenix area, with, unfortunately, patients being exposed to and developing disease from monkeypox at those events, bringing them back home into our communities, and then becoming their own patients of concern. That said, there is a robust vaccine campaign which is being provided through the local county health departments under the direction of the Arizona Department of Health Services and, of course, by the CDC with a what's called a ring vaccine strategy. So, patient with a known exposure then develops symptoms which are felt to be consistent with early monkeypox. That patient's first ring of contacts, partners, family members, etc., are vaccinated, and as more vaccine doses come online, will participate in a double ring strategy, ring vaccine strategy, which was shown to be incredibly effective in parts of Africa affected by Ebola virus. So you vaccinate the contacts of the contacts, and that effectively stops the spread. So that scenario is playing out extensively throughout this country and certainly in many other parts of the world. In Europe, there have been several pediatric cases reported. So far, we've not encountered that as a significant concern in the United States, but it's only a matter of time. That's unfortunate because guess what kids are being exposed to right now, which, at early stages look a whole awful lot like early monkeypox. Yeah, insect bites, other viral exanthems, potentially adenovirus, enterovirus causing a papular disease, certainly HSV, varicella for those kids who are at risk, even those kids who may develop a post-varicella vaccine exanthem. All of these lesions, unfortunately, look very much like the early stages of monkeypox. And it's only by careful history, looking for the preceding viral prodrome, which for monkeypox, flu-like illness, fever, headaches, myalgias, just like you would expect for the flu, followed 3 or 4 days later by the onset of pox. So lesions which start off as raised erythematous papules that rapidly develop a little central umbilication and then turn into a pox-like lesion. I encourage all of you to go online and look at pictures of the poxes in different stages. It's going to save you a whole lot of grief if you're seeing that patient in the clinic, the urgent care, the emergency department, the hospital. When the parents come to you with that question like, hey, I read about could it be this? I'm like, yep, we need to think about that. a lot of our patients were able to exclude from vaccine just based on epidemiology and on clinical appearance alone. So do, I think, if you can, do take a look at those pictures to familiarize yourself with what a true monkeypox range of lesions looks like. If you have a suspect case, the next thing to do is to contact your local county health department. They will have epidemiologists there to take your call, to get more history from you, to talk to the families, and very likely to request pictures that then are shared with an infectious disease consultant. So if you have a patient in whom you suspect the possibility of monkeypox, next step is to call your health department. And they are of course being overwhelmed by multiple calls, but this is what needs to happen so that we can have some sort of central response to assessing these patients. Monkeypox, by the way, there is an antiviral treatment that has been used in some patients, some adult patients with monkeypox. Those typically have been individuals who were very sick and had underlying immunodeficiency, especially including those patients living with HIV/AIDS. So the antiviral, as it turns out, can be used in ages younger than 18. The vaccine has been tested and is safety tested only over 18. So we're still working on getting pediatric indication for the interventions possible for monkeypox. Fortunately, though, the vast majority of patients with monkeypox, while uncomfortable, are all spontaneously recovering with a minimum of morbidity and close to zero mortality. The fulminant hepatitis cases that we encountered, starting 9 patients reported in Alabama. If you are a journal reading person, you likely saw both reports in the most recent, or actually last week's New England Journal of Medicine, which very accurately described the fact that adenovirus 41 has been demonstrated worldwide in many of these patients, these children, but it is not yet clear that is the smoking gun in terms of causing the fulminant hepatitis. In case you're just joining us for the podcast, the patients reported are really ages 1 year through 10 years, perhaps 12 years of age, who have a viral illness, again, flu-like illness, followed 2 to 3 days later by onset of jaundice, and when labs are performed, they show evidence of liver failure. So hyperbilirubinemia, decreased liver synthetic function. There has been worldwide a 14% mortality rate, so 14% of the victims known have died, and another 20% have required liver transplantation. Here in Arizona, we've had a couple cases, but so far no transplants, and fortunately no deaths. So the numbers of cases, however, have really dropped off precipitously, which further suggests, again, a seasonal virus, perhaps a cofactor, along with adenovirus, which, as we know, is a year-round sort of thing. But while we're still looking for the cases, we have not seen many in the recent past. Keep looking, keep looking. There may still yet be other things out there. And then I guess last but not least, what are we seeing coming into the hospitals? And again, it's a fair amount of both respiratory and GI viruses in terms of infectious diseases. And this is sort of what you would expect for a typical, late summer and perhaps early fall kind of process. Norovirus is definitely out there, so too is rotavirus. Although those numbers thankfully have dropped as we get further out from the summer. There have been clusters of bacterial enteritises coming to us, especially from some of our patients living on reservation land. So salmonellosis, shigellosis definitely out there as well. And then the respiratory viruses, still seeing a fair smattering of rhinovirus, enterovirus, some adenoviruses, and some enteroviruses. So there you go. That's sort of what we're seeing out there. Far more frequently, at least in the institution that I work at, have been, unfortunately, the mental health concerns. So again, a large number of our middle-aged and adolescent patients suffering from depression, anxiety, suicidal ideation, drug intoxication, intentional ingestions, etc. So our psychiatric colleagues are busy, as are the number of beds in hospitals being devoted to psychiatric holds, while we try and discover yet more inpatient psychiatric services. So as I'm sure you are all well aware, our kids are suffering, and as we get back to the school year, hopefully they'll be able to regain their social networks and have some sort of mitigation. But that may just only serve to allow the suffering kids who actually have depression and suicidal ideation to sort of fly under the wire as they hang in the fringes of their group. So continued screening for depression, continued screening for behaviors, and of course continued hanging in there for all of us. So with that, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. And again, and as always, keep hanging in there, keep fighting the good fight, and call for help when you need it. Thanks, everyone.